Now let's talk about how we are going to manage or treat a patient with CML. Historically, when there were not a lot of drugs, the patient of CMLs, the major chemotherapeutic agents that were used to treat CML were interferon therapy. There were certain types of other chemotherapeutic agents like hydroxyurea or busulfan. These were the treatment modalities. And then eventually, if we had a donor, then we used to do the stem cell transplant. But in the last 20 years, there has been miraculous advancement in the treatment of CML. And these are basically related to one type of the wonder drugs which we have discovered, which are the tyrosine kinase inhibitors. This group of tyrosine kinase inhibitors, which generally end in the suffix inib, like imatinib. Imatinib was the first generation, was the first developed tyrosine kinase inhibitor. Since the CML translocation, the 1922 translocation, gives rise to a tyrosine kinase product, these tyrosine kinase inhibitors are just the drugs that we needed. They are the ones which inhibit the tyrosine kinase enzyme, and they can lead to miraculous improvement in the patient's overall symptomatology and the patient's prognosis. The oldest one is the imatinib, and this is the one which is most widely used. Still, this is the gold standard of the tyrosine kinase inhibitors. There also have been certain newer generation of the tyrosine kinase inhibitors like dasatinib, and there has been nilotinib, bosutinib, ponatinib. All of these end in the suffix tinib, T-I-N-I-B. So this is T-I-N-I-B is generally what denotes tyrosine kinase inhibitor. How do these drugs work? They inhibit the enzyme tyrosine kinase. Tyrosine kinase is the major product of the CML translocation, and they specifically act on the CML cells and generally spare the other cells of the body. So they are very useful in controlling all the phases of CMLs. Generally, the chronic phase, we reserve imatinib. We also use imatinib as the first-line drug in the accelerated and the blast phase. And if we have a varied response to imatinib, we can move on to the newer generation of the drugs, the second and the third generations. And if we are unable to control the patient's symptoms with the help of the tyrosine kinase inhibitor, then there is another new class of drugs called the omecitexine. This omecitexine is a protein synthesis inhibitor, and it can also help with the BCR-ABL translocation. But this is generally used as a last resort after the tyrosine kinase inhibitors have been used and if they have been found to be ineffective. So for the chronic phase, we start off by using imatinib, and we use it chronically. It helps most of the patients. If the imatinib is not working, we can move on to the newer generation like the dasatinib or the nilotinib, and eventually we can also use ponatinib, and omecitexine is reserved for the latter part of the treatment, mostly the accelerated and the blast phase. There are certain various side effects of these drugs. They can cause variable bone marrow suppression, but not a lot of side effects as compared to the other chemotherapeutic agents. So these are very good drugs, very well tolerated, and they are widely used in the treatment of CML. Now let's talk about specifically how we are going to treat the accelerated and the blast phases. For the accelerated phase, we analyze the mutation first, look at the chromosomal analysis. As a first-line treatment, we start off the patient on imatinib. General dose is around 600 to 800 milligrams per deciliter. Or if the patient is a good candidate for the stem cell transplantation, we move forwards with this allogenic stem cell transplantation. But even for those patients, we give them a trial of imatinib for a short period of time. The alternative to imatinib or the first-line drugs are the second generation of the TKIs or the tyrosine kinase inhibitors, which involve the various drugs like the dasatinib or the other types of tinib drugs. And eventually stem cell transplantation, the allogenic stem cell transplantation is the curative therapy like the other phases of this treatment. Moving onwards, if we talk about the blast phase, the first-line drug is the same, imatinib. The dose is generally 800 milligrams per day. Or if we have a good candidate, we can proceed onwards with the allogenic stem cell transplantation. The alternative to imatinib and the stem cell transplantation are the newer generation. Even if we have a lymphoid, for example, if the patient goes into an ALL, if you have a lymphoid portion, Then we can use dasatinib chemotherapy. Dasatinib has been shown to be very useful for the patient with ALL. And even if we have the AML, like we talked about, we can use the second generation TKIs, yeah, like the dasatinib or the other ones, melatinib or certain other types of attenuators. And similarly, like to the other parts, the allogenic stem cell transplantation, just like the chronic and the accelerated phase, that is the most curative treatment that we have. This is the major treatment that is going to cure the patient, but we can't do allogenic stem cell transplantation for all the patients. That's why we have to rely on the tyrosine kinase inhibitors for a majority of the population, and they are very effective in controlling the symptoms of the patient or delaying the progression of the disease. These are the major first-line treatment modalities. The other treatment options, were the drugs that were used historically before the discovery of the tyrosine kinase inhibitors. These were interferon alpha. They are now very rarely used, and they are generally used in patients in which we do not, in settings where we do not have access to either tyrosine kinase inhibitors, or there, if we have certain contraindications for the tyrosine kinase inhibitors, which are not very much. So these were used historically and not much used. But for the matter of completion, interferon alpha was used historically for treating CML patients. The other chemotherapeutic agents were hydroxyurea and the busulfan. And eventually, if the spleen was too big to cause a lot of symptoms, we can do splenectomy in these patients as well, specifically if the spleen is pressing the stomach or the other organ, then it is leading to early satiety, or if it has outgrown its blood supply and we have splenic pain and there is a chance of splenic infarction, that can be a medical emergency as well. And for those patients, splenectomy can be very effective for the alleviation of the symptoms. So splenectomy is an option for patients in either any phase of the disease. We have to do serial measurements of the spleen and have to also find out that the spleen size is increasing either very fast or is it a slow growing phase. That also gives us a good indication of in which phase the patient is. If it is a very slow growing spleen, then we can say that the patient is in the earlier stages of the disease, either in the chronic phase. And if the spleen is growing up too fast, then we fear that the patient might be going into the accelerated or the blast phase. So splenectomy can be useful for the symptomatic management of these patients. Now let's quickly review what is allogenic stem cell transplant. How do we do this stem cell transplantation? Well, we take cells from the donor, a healthy donor. We take hematopoietic stem cells from the donor. We collect these stem cells and then we process them with the help of various agents and cryopreserve them for further use. There are stem cell banks which are used after cryopreservation, and these are the ones after HLA matching and the ABO matching with the various types of donors. We then use these cells to transplant into the patient. Then we also use certain types of chemotherapeutic agents to make sure that the stem cells which we have are free of any disease, and these are also effective during the cryopreservation period of the time, so that the stem cells do not impart any disease to the patient. So a few chemotherapeutic agents, very selected, are also used to make sure that the stem cells are healthy. And then in the donor, what we do is we start off with a tyrosine kinase inhibitor, specifically talking about CML. With the tyrosine kinase inhibitor or imatinib, we give a course of those drugs, and eventually, if the patient is free of the symptoms, we can also use certain other chemotherapeutic agents as well. And when the patient is symptom-free and generally in a healthy state, then we infuse those stem cells into the donor patient, and that eventually gives rise to the allogenic stem cell transplantation. And then these cells can generally grow, and over a period of time they outgrow the previous neoplastic stem cells, and the patient then can have a generalized good lifespan. He can have a generally healthy life as compared to the normal population. So this was all about the allogenic stem cell transplantation. And with that, we complete our discussion on CML. We started off talking about the basics, defining the terms, the various types of markers, what is the hallmark of this disease. Then we talked about the various signs and symptoms, what are the variable presentations, what is the etiology and pathogenesis. Later on, what are the diagnostic modalities what we have? How do we view the 922 chromosomal translocation, which is the hallmark of this disease? And eventually, we completed our discussion with the thorough discussion of about the treatment modalities. What are the newer drugs which we use? How do we treat a chronic phase? How do we treat the accelerated and the blast phase? And then we completed it with a small discussion of the allogenic stem cell transplant. I hope you have learned something, and I'll see you in another lecture. Thank you for watching sqadia.com.